Hello everybody, my name is Bogdan Goga, I'm a Romanian physiotherapist, and today we're going to have a very nice and I hope interesting discussion about headaches, about migraines, about pain around cervical spine and the head. With me are two very good friends of mine, but also esteemed colleagues, Andrei Gheorghiu from Romania and Romain Diop from Belgium. Also, we have a special guest, a neurologist, a medical doctor who takes big interest in treating headaches and migraines and all this type of pathologies, Michel van de Het. And guys, I welcome you and thank you for accepting this invite for this topic. It's a very interesting and sometimes maybe not so keen to physical therapy because when I started working in a neurology department, there was not so much treatment done for headaches or migraines by the physical therapist. But we see now that our profession, it's going in that direction and it's going in to be included in treatment of this type of pain. I will start the discussion with my colleague in the left, Michel. How do you define a headache and how do you define migraine? Because sometimes we see that these terms are not really known and sometimes you get confused.
Yes, but for us, for neurologists specialized in headache therapy, headache is the generic name, just to say that you have pain in the head.
Okay.
And then after that, you have subtypes of headaches, like migraine, cervicogenic headache, cluster headache, and so on. And there's almost 190 other headache in the classification of headache. You define the type of headache the patient is suffering just by asking question about his headache. So you just have to describe the headache. And we have what we call diagnostic criteria. Mm-hmm. Let's say for migraine pain, the patient should suffer from headache lasting from 4 to 72 hours without treatment, at least 5 times in his life. Mm-hmm. And the headache should have 4 characteristics. It should be unilateral, throbbing in quality of pain, aggravated or worsened by exercise or coughing, and it's a pain that is at least moderate to severe. But on those 4 characteristics, you only have to have 2 of them to be a migraine. So migraine is not only a one-sided headache. If you had a holocranian headache, so on both sides, but it is severe and pulsating, it's still a migraine. And furthermore, with this characteristic of the pain, the patient should also suffer either from nausea and or vomiting, and also he should be sensitive to lights or to sounds.
Okay, so if you got symptoms like pain, but only pain, you cannot really say it's a migraine.
No, it's insufficient. You don't have enough information to get the diagnosis.
There is another misconception because you get me with that. A lot of when you go in the social media, you can find like if you get pain here, it's tension type. If you get pain here, it's C3 type.
We have types of charts.
Yeah,
yes.
Like body charts, like determine your diagnosis, but it's quite poor.
Yes, it's too restrictive.
Yeah, we need to know all the story.
More information. Yes.
Is it important to know and understand about the type of the headache that the patient has? Or at the end of the day, they will receive the same treatment?
They won't receive the same treatment. You don't treat a migraine patient as you treat a tension type headache patients or a cluster headache patients or only cervicogenic headache. You don't treat them the same way.
Okay. So it's important for you to better understand the
Yes,
situation.
sure.
And this way, you can conduct the treatment from the point of medicine.
Medicine. So it's the most important part for us is the diagnostic. Mm-hmm. If we have a wrong diagnosis, you will have the wrong treatment.
Okay.
And going to that idea about diagnostics, what are the outcomes? For instance, what are the outcomes for a migraine patient, and what are the outcomes for a cervicogenic or a tension type headache?
Yes. I don't have the numbers for every type of headache, but for speaking about migraine, you have 2 types of treatment. You have the acute treatments, so when the patient has a headache, he should take painkillers. For those treatments, it's mainly 60 to 70% of patients who are improved after 2 hours. And after that, you have also what we call the prophylactic treatment or the preventive treatment. It's just to lower the frequency of headache in those patients. And with almost every treatment we have so far in migraine, we have at least 50 to 60% of change to improve our patient for more than 50%. So if he has 10 days per month of headache with a prophylactic treatment, we have 5 to 6 change on 10 to bring him under 5 days per month. These are the numbers with the study.
So, because most of the treatments, as far as you describe, are with drugs, with medicine,
Sure.
Don't we have the problem of over-medication?
Sure, the studies are only made with drugs, but in practice we do not use only drugs. I work a lot with Romain Giop, so we have a mixed treatment with drug treatment and physical therapist treatment. There are no studies comparing the effects of only drug treatment to drug and physical therapist treatment. But we combine them, yes.
The thing, to help people to understand it, what would be your criteria in your head to send the patient to the physical therapist? You know, when you get the patient, they speak about his story, and what's the tricky things that you use to send to yourself, okay, I'm probably getting to physical therapy?
Again, I will talk about migraine because these are the more frequent patients I see in my practice. I focus mainly on the cervical, upper cervical spine and the ATM joint in those patients. If they told me during the history taking that they have pain starting from the back of the head or in the ear or something like that, and then during the consultation I will palpate the cervical spine and the ATM, and if there's something wrong with it, pain in the ATM or muscular trigger point, I'll send them.
Yeah, so it's again the same things for us in our physio concept. It's finding some assessment which is reproducing the pain of the patient, or finding some mistake of mobilization or miss of mobilization, which is fitting for us.
So we need to find a comparative sign.
Yes.
And afterwards to see if with exercise or with manual treatments we can improve it. Because sometimes headaches can be debilitating. They can mess up the life of the patients. What do you think it's more important, reducing the symptoms or educating the patients?
Everything is important. You have mainly to educate the patient, to inform the patient about what is suffering so he can understand it better and cope better with it. You have to lower the frequency of headache. You have to lower the number of painkillers they should take and so, to improve their quality of life. That's only what it's about. It's to improve their quality of life. Whatever the way you use to achieve it. The other thing I think it's not about I think headache is not that much complicated to understand and to manage. It's just because it's not well known by the literature and the colleagues. I get the feeling of that. But it's like misdiagnosis or underdiagnosis, pathology or trouble. You know? And undertreated, mainly. And undertreated.
I think that most of the people just go to the pharmacy to treat a headache.
Yes.
They don't actually try to find a way for physiotherapy, or they don't. How many patients come for physio, especially for headaches?
Well, yeah, the numbers are small or little in this, but we see nowadays that there is a shift in also the specialist point of view, and started doctors to understand and to send patients to physical therapy. But yes, we don't have such big amount of patients who come for treatment for their headache to physical therapy, like in your practice, because you see mostly
I see only that.
Only patients with headache in a city that is not bigger, let's say, than Bucharest. It's more small.
Of course.
So it's a very common thing, we know. No, the headache, it's something that everybody will have.
Yes, migraine, it's 1% out of 5.
Yeah.
20% of the general population suffer from migraine.
Yeah.
So it's really common.
It's massive.
And when we talk about migraines, we need to have at least 2 of the things that you presented.
Yes.
And is there anything else that's more specific for migraines, or just the presentation of the pain?
It's just the presentation of the pain and what we call the accompanying symptoms, so nausea and or vomiting and phonophobia.
Okay.
Yes.
But is the level of pain an indicator for the level of, let's say, seriousness of the situation? So the bigger the pain, the bigger the problem?
Yes, sure.
Really?
But no, for the quality of life point of view for the patient,
Okay.
if it,
A neural or a pathological point of view.
no, that's not that important because mainly if they don't treat the migraine attack early, they will get a worse headache.
You know, because we tend sometimes, to say, okay, if it's that big of a pain, definitely it's very something wrong there. But
no,
this is not really the case.
The pathophysiology is quite the same underlying the disease. So it's not like a pain with arthritis, or of the pain is parallel to the importance of the arthritis. It's not that kind of relation in migraine.
Okay.
But at the same time, we know that pain is subjective. So
yes,
pain,
sure.
It may be big because you are from a long time in pain,
Sure.
and because it modifies a lot the life that you are living.
Yeah.
And we know also the beliefs play a big role. And we know that the fear avoidance behavior can really raise the level of the pain.
And the other thing about the beliefs of the patient, a lot of patients believe that if they get really frequent migraine and high migraine, like something could happen in our brain, like some damage or nothing. Because this is a real belief that people have.
Yes.
They are afraid of that. And
I will get a stroke.
Yes, no, that's a strong belief. Yes.
Yeah. And
it's a wrong belief.
Yeah, it's a wrong belief. Yes,
nothing.
sorry.
So if we look at the brain of a migrainous patient with a lot of frequency and intensity, it's quite a normal brain.
Oh, there's some studies showing that you have a little bit more of what we call white matter lesions in migraine patients, mainly in migraine with aura patients, but we don't know the meaning of it. And it's not related to the frequency of headaches.
Or something bad, tumoral
or stroke or no.
Because we know in physical therapy, like when people have low back pain, they tend to avoid the movement. And this is worsening them.
On the long term.
Yeah, but if with the pain they move the back, nothing happening in the back, nothing is decreasing or something like that.
Yes.
So it could be quite the same for migraine.
Yes, it's not aggravating. The frequency of headache doesn't aggravate if they have those type of lesions.
So if a patient has a migraine, could be better for him to stay active and stay in the life than retreating and retreating himself. It's really our psychosocial approach.
And we know that the physical activity is important in migraine. People who came with chronic migraine, we ask them to have physical activity at least 2 or 3 times a week instead of staying home without doing nothing.
Okay, because physical exercise in general
is good for health.
Yes, it's good for health, it's good for
the brain,
for the brain. So it's very important from my point of view, and I see that for everybody, that people need to receive a very good education about their problems. They need to have a proper diagnostic, good education about the problem. The medication should be there, but not permanent.
Yes.
advice for exercises and for physiotherapy. But what can we do as a physiotherapist? The thing is, the first step will be, as always, as physios, would be an assessing and a medical assessing, and of course examination and speaking with the patient.
And the assessment is based on the medical diagnosis.
Yeah, of course. No, not that much. I get quite the same assessment for all type of patient, because I see my assessment like, okay, this is a headache, and we got some structures connected to the headache, like muscle structures, articular structures from the jaw and from the upper cervical spine and global cervical spine, I would say. And the idea is, okay, from our physiotherapy, we get that first point of view, like manual therapy point of view, like mechanical approach, and we check the mechanical stuff. If response or not, would probably indicate if we can help the patient or not. To be honest, in Belgium, the red flags would be meaning, okay,
Accident.
People are so over-medicated and have so much and so many complementary examination in Belgium. It's quite like you can't miss it, red flags. The last red flags I had was like really common, like the sister of a dentist which I'm working with, and she made a car accident, and she came to the clinic, and she got a big blue hematoma in the neck, and the eyes was like blue again. Of course.
But she came to you for her pain.
She came 48 hours after the car accident.
With no X-ray?
No, just because she did the car accident, then the blue appeared, and then the sister said, "Oh, go to see Romain, he can fix your headache."
Yes. What do manipulation?
So this is really massive, and there is some papers now which are going through our physical therapy, like red flags. It's like a bit like the monster under the bed. We are all afraid of that, but
you don't see them very often.
Yeah, and when you see them, we are really effective and strong to
recognize.
Yeah.
I totally agree, because they are totally unexpected, and they don't follow any kind of patterns. They don't. I have a big accident before, or I have a pain that cannot be modified in any type of.
Or strange symptom. Another one, a colleague of you, sent me a patient. When she does this with the eyes, she vomits directly. So this is too strange for 50. What do you want me to do?
And did you let her do this in the office?
Don't move the eye, please.
Give the eyes down.
So this is quite common about red flags or something like that. And the other thing is, to me, the most difficult things is to make the patient forgetting his complementary MRI, for example, with arthrosis and blah blah blah, and she's afraid all come like you said. We said yesterday night, like patient come with this is
file,
my history,
medical file.
What do you do in that case? For example, this is really important.
Okay.
As doctor, what do you do? The patient come with, okay, this is my story.
I take the medical file, I put it aside. I say, let's start again from the start.
You give it to your nurse to make a song?
No. Unfortunately, I don't have this kind of nurse, but no.
Yeah. So even for medical doctors, this is important, because I think for everybody.
But
we need to.
You're talking from a bias point of view, that you can become biased.
Sure.
And influenced by
the medical
papers.
Yes. Because if there was a mistake in the medical file, you will only repeat the mistake. So I think you should really start from the start with the patient. Furthermore, if you see it for the first time.
Yeah.
Especially if the patient is overdiagnosed and had 3 MRIs in the last 2 years, 3 PET CTs and so on, and he saw everybody.
Eric's.
Yes.
And if nobody saw anything wrong in that, okay, why should I see something else in the files? I think coming to your question, it's very important to speak with the patient, understand the patient, and listen to the patient actually, because each one of us is different, and each one of us has his own story. Yes, we have some symptoms that are very similar to another one, but they may have other causes that can be on the root of the problem. So always talk with the patient, listen to the patient. We as physios, we have this big fault in our star. We don't listen too much to the patient because we think that we know that the problem. So they made the study, and we listened to the patient only 16 seconds. After 16 seconds, we stop the patient and put the question.
I know the problem.
Or tell them directly what we think it's going on.
Okay.
Yeah. So we can end with this idea. We should listen more to our patients. Like our esteemed colleague here said, he starts all the time with very good history taking, and I can say to you that we also as physios, we should start with a very good history taking, and the diagnostic and then the physical therapy assessment are very important in the directions of treatment. And as a conclusion, we can as physical therapists, as physiotherapists, treat headaches, but we should really know the type of it, and we should really have a medical diagnosis in order to choose the best techniques and have a very good outcome or understanding the outcome. Thank you very much for watching us. If you have ideas, comments, we are very eager to hear from you. You can write in the comment section, or if you want, we can share our email address and you can write to us, and hopefully we can exchange ideas or opinions, because this is how we can all become better for our patients. Thank you very much, guys.
Thank you.
Thank you.
Very lovely discussion, and hopefully many of you will find this interesting and helpful.